Womack. I'm a pediatrician with the St. Luke's School Mobile Clinics in Boise and Nampa. All right, well, let's start. I have two topics today, stabilizing injuries and seizure disorders. And we're going to start with seizure disorders first. Here are our objectives today. I'm going to outline the school nurse scope of practice, discuss the important role of nurses in seizure management in the school setting, and then finally discuss triage and management of common injuries. So on a federal level, here are the laws around school nurse scope of practice. The IDEA, the Individuals with Disabilities Education Act, regulates certain services and requires school districts to provide the related nursing services necessary to ensure that children with disabilities benefit from special education programs. And then I'm sure all of you are familiar with Section 504 of the Vocational Rehabilitation Act of 1973. We usually just call it a 504 plan. But basically, it requires school districts to provide a free, appropriate public education to handicapped persons, regardless of the nature or severity of their handicap. And then just FYI, ADA, the Americans with Disabilities Act, extends that same provision to other public areas, including childcare and also private schools. So that's the federal level for scope of practice. As school nurses in Idaho, there's not really a lot in the statute. This is all I was able to find. There's a section 33-520 that talks about permitting students to self-administer certain emergency medications, including metered dose inhalers for asthma, epinephrine autoinjectors, diabetic medication, and actually also use of glucometers. And then there's a subsection of that same law that mentions that schools may have their own supply of epinephrine autoinjectors and that school nurses may administer that to any student they feel in good faith is having an anaphylactic reaction. And that is important because there are quite more than you would think, quite a number of patients who their very first knowledge that they even have a food allergy is an anaphylactic reaction. So that's it on the state level. This is a screenshot from the Idaho Department of Education on school nurses, and it goes into a little bit more about some of the things that you guys do on a daily basis. So that includes appropriately managing health conditions holistically, removing obstacles to student success, utilizing technology like AEDs, engaging with professional learning communities and working partners to further education, which is what you're doing today here. Demonstrate evidence of impact through data that you collect, and then offer services within schools, including prevention, such as scoliosis screenings, vision screenings, etc. And then what we're going to talk about today, first aid and emergency care. So we're going to first take seizures. Definition of seizure, the best one I found is period of abnormal brain neuronal activity that leads to disruptions of normal brain function. And that usually leads to signs and symptoms, of course. And then seizure disorder, which we use interchangeably with epilepsy, which is a chronic condition that's characterized by recurrent and unpredictable seizures. So it's pretty common. 470,000 children in the US have epilepsy, which gives it an incidence of 6.3 in 1,000. So chances are, even if you're not in a larger school district, if you've been in practice for a while, you will have these children in your schools. It's an expensive disorder, $9,000 per patient annually, and it even goes higher if the seizures are uncontrolled. And then 1 in 4 children with epilepsy have other conditions as well. And the most common ones that are related to seizures are things like cognitive delay and learning disorders. So here are the most common types of seizures we see in children. The most common are febrile seizures, but we're not going to spend a lot of time on those today because typically those present in terms of age of onset around 1.5 years, 2 years of age, and are usually outgrown by about 6 years of age. So unless you're in a preschool setting, you're not going to see a lot of those. And they tend to only have, the average child with febrile seizures will only have a handful. So it's not like something that's quite frequent. Probably the one that you have seen, and it's the most common type of epilepsy in childhood, is benign Rolandic epilepsy. It's now called either benign epilepsy with centrotemporal spikes or epilepsy of childhood with centrotemporal spikes, just to be more specific about the EEG findings. And that is also outgrown by the time they're in adolescence. In fact, all of these, the most common seizure types, children outgrow before adulthood, which is great. Benign Rolandic epilepsy, typically those are partial or focal seizures, which is versus generalized. So that means it's just one part of the body, it's unilateral. And it's called Rolandic epilepsy because the seizures originate in the Rolandic area, or Rolandic fissure, which is what that yellow arrow is pointing to. So that fissure is that pink line there. And that area is responsible for the function of especially movement of face and oropharynx. And so typical symptoms include facial twitching, stiffness, numbness, and tingling of the face and throat. Oftentimes, these kids will be sitting and staring off into space and then either licking their lips or smacking their lips. That's pretty common. They're usually short-lived seizures, 2 to 3 minutes, so don't typically need any kind of PRN medication, but occasionally the seizures can spread, and they might start in the face, but they can spread down the arm, and every once in a while you can have a generalized tonic-clonic seizure, which will require treatment if it's over a certain amount of time. Since the age of onset is in elementary school, you might see this. And like I said before, this is one of the ones that almost always resolves, something like 90-something% resolve before they reach adulthood. Absence seizures is also something that you may see. It's the second most common type of seizure in childhood. And those are, they look like brief staring spells, and I have here up to 30 a day, but you can actually have up to 100 a day. They only last seconds, and they can be missed. Over the years of my practice, I've actually had school personnel help me recognize and diagnose absence seizures. It's hard to diagnose sometimes because they are so brief, and it just looks like a child who's staring off into space. But what really delineates patients having these absence seizures from other children who are just not paying attention is that you cannot get them to look at you. So they're usually actually unconscious. So they have an altered state of consciousness during these seizures. And so you can snap your fingers in front of their face or wave your hand, and they will not respond, at least for that several seconds. And the good thing about this one also is that with or without medication, there's typically spontaneous resolution. The ones that might be more under your auspices in terms of needing seizure treatment are children with syndromes like Lennox-Gastaut. Those children tend to have more generalized tonic-clonic seizures that may not be self-limited, might require treatment. And then also I have here autism spectrum disorder, because we're learning more and more about autism spectrum disorder, and that there are multiple genetic mutations that can lead to autism spectrum symptoms. And some of them are also associated with epilepsy. So there's a patient or a student in one of my schools that I go to who has autism spectrum and seizures often enough that even if they have multiple seizures during the day, they're able to stay at school because of the fantastic school nurse that's there. So just a few random seizure facts. A typical seizure does not cause lasting brain damage. So you'll often see in a seizure plan that after 5 minutes of a seizure, you should administer the PRN medication. That is not because we're trying to prevent any kind of long-term damage. That's mainly, honestly, for more practical and logistical reasons. So you're not rushing to prevent brain damage, and it's if you're not able to get the seizure stopped, even after 10 or 15 minutes, that's not a fail on your part. It's just you just want to stop it, because it's true that after about 20-30 minutes, a patient is more likely to end up with something like status epilepticus. But again, 10, 15 minutes is not going to be, will not cause any kind of long-term harm to that child. And this is just a pet peeve of mine. Seizing is not the correct way to say somebody's having a seizure. You either say having a seizure or convulsing. Again, that's just a little thing that I'm just going to throw out there. And then arguably the most important point is that one of the main reasons to identify children who have a history of seizures is then if a student's having a seizure for the first time, you know it. Because if there's a child who has no history of seizures and they have a seizure, especially if it's a generalized tonic-clonic seizure, the differential diagnosis is vast. They could have a space-occupying lesion. It could be infection like meningitis. It could be either an accidental or non-accidental ingestion of a substance, and so that would require calling EMS sooner than later. So this is an example of an individualized health plan for seizures that I took from the National Association for School Nurses. I love this website. I've gone to it multiple times since I started working in the schools. And I particularly like this form, and I'll show you why. First of all, for contact information, it does acknowledge that there are times when there's a family member, a mom or a dad, who should not have access to records and should not get contacted. And they have a space, they provided a space for that. I like that they acknowledge that a patient can have more than one type of seizure. And it would be good for you to know if you have a patient who has Lennox-Gastaut syndrome and they've got 2 or 3 common seizure types, and you know this, but they're having a one that's a little bit different. That is something that the family and that patient's provider needs to know. I like that they have the triggers on here because let's say the family says, oh yes, flashing and bright lights trigger seizures in our child. Well, that would be good to know before the first fire drill of the academic year, right? And then obviously you'll need to know if a child has a vagus nerve stimulator, and on obviously how to use it, what the PRN medications are. I like that it has a provision here for diet because that's going to be good for the food services folks to know. And then activities, right? So you want, again, it's all about inclusion. So making sure that these kids get to go on those fun field trips too. But it's good to think about what that looks like. Does the school nurse have to go? Does the PR medication have to go with you? All of those things are good to know in the beginning of the school year. This is also from that same National Association of School Nurses website. I really like this emergency plan, and it's not for you guys, it's not for school nurses, it's for school personnel that might happen to be the first on the scene if somebody's having a seizure. I love the first 3. So number 1 is call the school nurse for assistance because you are the medical expert in the building, and you need to be called first thing. I love that number 2 is stay calm because let's face it, seizures are very distressing and disturbing and upsetting, especially the generalized tonic-clonic seizures, especially if you're not a medical personnel. So, just remind everybody to stay calm. And then, of course, timing the seizure is important. For a lot of the seizure disorders, we do have that relatively arbitrary cutoff of 5 minutes for treatment, again, for all sorts of reasons, but not because you're trying to prevent brain damage. And then, of course, just making sure that child is safe, that there's nothing that they can injure themselves on, like a desk or a chair that's too close. Want to keep them on their side, keep their airway clear, the typical ABCs that you all know. And then this is absolutely true that a school nurse's response to seizures is critical for a child's success in school, and not just your response to a child's seizures, but your response to the child and how you deal with the child, interact with that child themselves. And the school staff is going to take, they're going to look at how you interact with that child and use that for their own interactions. I see it not often, thank goodness, but if that certain children with certain syndromes or symptoms or medical diagnoses are treated differently, almost like they're fragile, like that people treat them with kid gloves. And you can set the example of, as long as you know exactly what's going on with their medical care, you don't necessarily have to do that. And that can, make or break how a child does in school. So these are some of the things that you're responsible for: decreased number of inpatient hospital admissions and school absences, increased safe inclusion in school activities like field trips, decreased time spent out of the classroom, increasing that student's success and quality of life, and increase return to class when it's safe and appropriate, and decrease unnecessary emergency room visits. So we're going to turn now to injuries. Shifting gears here. So we're going to be mainly talking about unintentional injuries. And among children ages 1 to 19, unintentional injuries are the leading cause of death for every year of age. And half of those are from transport. And what I mean by transport is motor vehicle accidents, pedestrian accidents, bicycle accidents. The two most common causes of non-fatal unintentional injury are falls and then being struck by or against something. So since those are the two most common causes, I'm going to concentrate on falls, since that's what you're going to see the most of in terms of injuries in the school. I like this definition of fall injury. It's defined as injury received when a person descends abruptly due to the force of gravity and strikes the surface at the same or lower level. It's pretty self-explanatory. When I was preparing for this talk, I was just polling school nurses about some of the things that they see the most, and it is probably falls, or in the older grades in junior high school, weightlifting injuries from free weights falling on a student. And then this last point here, and it's not, we're not going to talk about this today, but just to remind everyone that the most important aspect of unintentional injury treatment is prevention. Lots of these injuries that we see are preventable. So your job as a school nurse in terms of injury is different than my job. My job is to diagnose and treat injuries, and your job is to triage, which sometimes is a little, honestly, more difficult, or it's certainly as difficult as my job. So the three triage decision nodes are: can that child stay at school with a little bit of treatment? Do they need to go home before the school day ends, or do you have to call EMS? What helps decide which way, which decision you make include these things: mechanism of injury. Sometimes you don't have any adult that witnessed the injury, or even an older child, but as much as you can, trying to find out how the child got injured can really help you make that decision. Amount of pain the child is in, which of course you have to take with a grain of salt, depending on the student and depending on their age. And then superficial or visual examination of the injury, looking for swelling, bruising, deformity, color changes. And when I teach to medical students, I always say, if you're looking at an arm and a leg injury, you always just put those the two limbs together. So if it's a right wrist injury, you want to do the visual examination of the dorsal and ventral side of both wrists at the same time, to discern if there's any, especially mild swelling or discoloration. And then, of course, the rest of your exam, which it will include temperature, pulses, perfusion, paresthesia, numbness or tingling. If there is a maximal point of tenderness, range of motion, if there's a joint involved, and then weight bearing if it's a lower extremity. And then, of course, your experience. So we're going to take a few cases. The first case is going to be a third grader fell and skinned her knee and palms, comes crying and limping into your office. When you ask about the pain after she calms down a little bit, it seems to be minimal. When you ask where it hurts, she kind of points all over. She doesn't point anywhere. She just says, sort of around the knees, sort of around her hands, but certainly no one particular place that she can point to. You inspect both hands and wrists together, and you inspect the knees together, and you don't discern any swelling, and range of motion is intact. So I think most of us would do our RICE protocol, which is the rest, ice, compression, and elevation. And then this is what I call waiting them out. So I actually worked kind of as a school nurse when I first started working in school clinics. I didn't have a mobile unit. I was actually in the school nurse's office. And so I saw a lot of these kiddos, and I would basically just wait them out. I would give them a book. I wouldn't make it too interesting in the office, and they would just be there on the bed, and I would be doing my work. And after 5 or 10 minutes, even if they came in bawling and I want to go home, after 5 or 10 minutes, sometimes they would say, "When's lunch?" or "What time is it? What am I missing? Is it recess yet?" And usually, if they say things like that, they can usually stay at school. I will just put in a plug for calling parents, even if it's minor injuries. If it's enough to send that child to your office and for you to put some ice on it, I do think families do appreciate a call. Here's our second case. So now we have a junior in high school playing basketball and was running, tripped and fell. They're non-weight bearing. They got to your office with the help of two buddies. And he's complaining that he twisted his ankle and now he can't put any weight on it. Let's just say, for sake of argument, it's his right ankle. So ankle inversion injuries are very common. Some of the most common orthopedic injuries that you or I are going to see. And if it's an inversion ankle injury, the most common ligament that's involved is the anterior talofibular ligament. So everybody take a second and feel your right ankle, and you want to feel that lateral malleolus. So that's that bony prominence on the lateral side of your foot, so the outside of your foot. So that's the lateral malleolus. Just distal to the lateral malleolus is this anterior talofibular ligament. So when you're inspecting this student, you're going to put his ankles together. You're going to try to see if there's any swelling, and particularly you want to look for swelling over the anterior talofibular ligament. And you also want to palpate gently over this, because if there is an ankle sprain, a significant ankle sprain, they are going to have point tenderness and swelling over that ligament right there. So it'll be basically between that lateral malleolus, that bony protuberance on the outside of your ankle, and between that and the base of the fifth metatarsal bone here. And I mean, you can say with some certainty to that student that he has an ankle sprain, and that will probably, especially if they're not weight bearing, will require a visit to a provider, if nothing else, to get something to immobilize the area. So the gray areas that you see here that are marked A, B, C, and D, they did this interesting study of ER nurses to determine whether or not someone who had an ankle injury required an X-ray, because the vast majority of these anterior talofibular ligament injuries, these ankle sprains, do not require an X-ray. I think they're definitely over X-rayed. And so the study took ER nurses and basically tried to see how good they are at predicting if a patient needed an X-ray, and if they had an actual fracture that would require an X-ray, using the Ottawa ankle rules. And the Ottawa ankle rules are that if you have any point tenderness in any of these gray areas, then that could mean that patient has a fracture. So, because these are the four most common places to have a fracture if you're going to have an ankle fracture, and that is the distal end, or the bottom end of the fibula, which is A, the base of that fifth metatarsal bone, which is this D, and then on the medial view, it's going to be that distal end of the medial malleolus. So that's going to be the end of your tibia, and then that bony prominence on the medial side, on the inside, and then C is the navicular bone. So when you're examining an ankle, especially if it's an inversion injury, look for signs of swelling and pain in this area right here, because that's going to give you the most bang for your buck. And then also you want to palpate all of these areas here, and that will make you a rock star with this family, because you could help them either avoid a trip to the physician, or you can nail the diagnosis. Next case is a fifth grader who was playing outside in the playground and fell on his outstretched right hand. So you do your visual inspection, putting his wrists together. Not a ton of swelling, but you palpate along the distal edges of the radius and the ulna, and there is some point and tenderness along that distal radius. And here's X-ray of that child. And this is a buccal fracture. It's also called a torus fracture. So this is, again, going to be one of the more common things that you see. A lot of times they don't have any bony injury, but if they're going to have a bony injury, depending on how significant the mechanism of injury is, it's going to be this buccal fracture. Does not need casting per se, it just needs immobilization, but it's good to know, and it does require an X-ray. It is not a through and through fracture. As you can tell, there's no actual breakage of the bone. It's actually more like the bone is accordioned in on itself, because in children, their bones are not calcified yet, right? So it's just kind of pushed in on itself. And you can tell it's that happened because you can see this outpouching of the periosteum right here. And actually on this X-ray, I noticed there's a step off here. So he actually has a buccal fracture of both the radius and the ulna. And so that is something that you want to look for and rule out when you have a child with a wrist injury, especially if it's a fall on an outstretched hand, because that's typically what happens when you're trying to break your fall, right? You put your hand down. And that's one thing that you can, again, really help that family and that provider if you can say yes, and they have significant tenderness and swelling in that part of the wrist where you're most commonly going to have a buccal fracture. All right. And then lastly, seventh grader, unwitnessed fall, and they actually call you out to see them outside because they don't want to move them. Child is crying, saying she's not nauseated, holding her right elbow, and all she can tell you is that she fell. Her right, you do your visual inspection, her right hand compared to her left is cooler, paler, and you can't find her radial pulse, and she refuses to grip your fingers with her right hand. So that is an emergency because that could be compartment syndrome. And you don't have to memorize the 5 Ps of compartment syndrome. Usually these kids don't look good, and their pain is significantly more than you would expect for the type of fall they have. There's a timing issue with this because if there's no perfusion going to that distal extremity, that leads to tissue death, and that is not a call the family first. You want to get EMS, and that's going to require surgery. And that's also true for possible like a severe dislocation of a joint can also compromise circulation distally on that extremity, or especially like a compound or severe fracture of a bone. And then last slide, the more serious the injury is or seems, the more important it is to immobilize. Again, in Nampa, in an elementary school, child sustained a compound fracture. I wasn't there, but the nurse wasn't there actually, but the front staff just took a blanket and wrapped it all around the child's arm and their trunk so that it couldn't move. And it was absolutely the right thing to do. So we have these SAM splints in our clinic, but as you can see, you can even just use a rolled up magazine and a shirt, and then just tie that together so that across, especially across the joint, if there's any worry about the joint, with something like this. Um, Again, as long as it's immobilized, the child cannot move it, then you're good to go. And that is it. I'm going to stop sharing.
Thank you, Noreen. So let's open it up to questions. I'm actually going to give you all the ability to unmute. Okay. Does anyone have any questions? No? Okay.
Hey, sorry, this is
Yeah,
Renee. I have
go
a
ahead.
quick question. What besides, this is going to be a very vague question, but we were putting together trauma kits just in case for some of the main classrooms. What would you suggest besides like the obvious finger splints, SAM splints? We've got those emergency zip sutures. Are there any other, I guess, common splints or common trauma pieces that we should have?
How much room do you have? It would be nice to
Right?
stabilize. What was that?
I said, right? 5
Yeah.
suitcases.
I mean, some sort of soft neck collar would be nice.
Okay.
And one of those SAM splints that I showed in that last slide are kind of nice. But again, you can use anything in a pinch, but SAM
Right.
splints are made for emergency immobilization.
Yeah.
And they roll up, so they're pretty small.
No, the neck collar is good because that's not even on our list. So thank you.
And protocols, just put things in there that, because it's usually a panicky situation, and so protocols for, like, post concussion care, like immediate post concussion care, or immediate um, um, hemostabilization, so hemostasis, what you're supposed to do, just
Right.
basics, is nice in there too, probably.
Thank you.
Thanks, Renee, for that question. Does anyone else have any questions?
I just have a comment, if that's okay. Noreen, great presentation. We have seen an uptake in seizures. We used to call them pseudo seizures, but mental health related seizures. We've had 3 this year, which I've never had one at school. 3 different students with trauma background having these pseudo seizures, and no history of any other type of seizures. So just to keep that in the back of your mind as well.
Right. And if it's a clinical person, you can tell right away they're pseudo seizures. Sometimes it's convincing the family, right? There's certain types of, or I should say, there are actually common types of pseudo seizures that children think might look like a seizure, but just, for whatever reason just doesn't make sense neurologically or anatomically. But yeah, you're right. We have seen those too. And sometimes the problem is convincing the family that they aren't really seizures, which takes a hospital admission and continuous EEG, etc. But yeah, good point.
Thanks, Cindy. We have a question from Bonnie.
Hello, can you hear me?
Yes, we can.
Great, thank you. Thank you so much for the talk. This is great. So I'm a school nurse and see a lot of kiddos who are very convincing that something is wrong, that they can't bear weight, that sort of thing, but turn out to be fine. Do we have any good tests or telltale signs for those kiddos?
I would ask other school nurses about that. I mean, like I said, I was only school nurse for about a year and a half, but I found the bore them, wait them out, especially in the junior highs. I wouldn't call it a protocol. It's just something that I ended up doing, because I just made it so boring in there that they wanted to. I was like, okay, let's see if you can bear weight now, because I'd say, okay, you have to be here for 20 minutes, and after 10 minutes is fine, but especially if I was like, you shouldn't have your phone, let's just see And if you take their phone away and they want to just prove that they can leave your boring office, I found that to be helpful. I don't know. Please, another school nurse, help me with that one. Because you're right. There's some that just want to hang out. Some just want to hang out with you. And so it's a matter of like, do I let them? Are they really non-weight bearing? I think those are honestly like on an individual basis. You guys get to know your students really well. You know the frequent flyers, and you know the ones that if they're in your office, they're probably really hurt. So I'd love to hear. Yeah, thank you, Renee. Boredom cures a lot of things. The key is taking their phone away if they're older, or giving them a book when they're younger. That's not that exciting. And yeah, they're going to be, is it lunch yet?
Tracy, did you have anything to add?
Yeah, I was just gonna say distraction, which is similar to boredom. Hey, do you want a cup of water? Here's some water. They'll jump up quick. Hey, to check I know you said leg, but sometimes shoulder. I'll say, can you remove your sweatshirt so I can see?
Yeah.
There's things that you get them to do that they want to help or whatever, that they'll quickly jump in and get distracted and let you know that they're okay.
I often find that that's the time where you can really engage with them on a social, emotional level too. Obviously, they're seeking something, even if it doesn't seem to be a true injury. And maybe you can find another need that needs to be met a different way.